Mrs. Johnson?
Yes.
Hello, I'm Dr. Booth. What can I do for you today?
Well, I really need your help, doctor. I have a problem with chronic back pain, and I'm almost out of my medication.
You're from out of town?
Yes, we moved here last month.
Are you taking any other medicine?
Yes, for hypertension, but it's the morphine for my back that I need.
Well, this just seems like a whole lot of medication to be taking for back pain. You know, I'm not so sure that...
Look, I don't know what to do. I'm almost out of my pills. It took me 3 weeks to get this appointment. Dr. Winston said I could have a seizure or go into withdrawal if I stopped taking this abruptly. I really need you to help me.
Mrs. Johnson, I want to help you, I really do. But first I have to properly weigh all the information before I can prescribe anything. We need to try and keep a sense of balance about this, okay?
Learning how to keep our balance is an important part of growing up. Whether we're taking our first adventurous steps on solid ground or maintaining our equilibrium on top of narrow rubber wheels, a sense of balance keeps us from falling and out of harm's way. Hello, I'm Jack Bowden. I'm glad you could join us. Do you ever wonder if you could still ride one of these? Well, I might be a little shaky, but with practice, I'm sure I could get better at keeping my balance. The same is true in the medical profession. The practice of good medicine will keep you from losing your balance, especially when dealing with chronic pain patients. Practicing good medicine means weighing the needs of the patient on one hand and balancing it with the proper treatment, narcotics if necessary, on the other, without fear of reprisal from your licensing board. The purpose of this program is to address the concerns physicians have about treating patients with chronic pain, especially those who may require opioids, such as Mrs. Johnson. Let's see how they're doing.
What's wrong with your back?
I hurt in a car accident a long time ago. It never got much better. I can get around all right as long as I take my medicine.
Have you tried a pain medication like ibuprofen for the back pain?
That's like taking water for me. Only the morphine has helped. Besides, I got a bleeding ulcer with ibuprofen. Dr. Winston said I should avoid all medicines like it, including aspirin.
Mrs. Johnson, have you tried treatments other than pain medication for the back?
I've been through all that. I had 2 operations. The surgeon said there's nothing more to offer. I had physical therapy and biofeedback. I even tried acupuncture. Finally, Dr. Winston gave me the morphine, and it's been like a godsend to me.
You know, I'm still not comfortable with this dosage. Is this Dr. Winston's phone number?
Yes.
Well, why don't I give him a call and I can discuss your case with him?
Ever feel like you're walking a tightrope? Oh, you want to believe your patient, but you're not comfortable with the dosage. Are you being duped, or is there a real need here? What about the potential for drug diversion? Are the drugs being resold on the street? And are you putting your license in jeopardy? The medical board wants you to know that you are not putting your license in jeopardy if, in the practice of good medicine, you determine that your patient would benefit from narcotics. In fact, the Federation of State Medical Boards has expressed concern that fears of investigation or sanction by federal, state, and local regulatory agencies may result in inappropriate or inadequate treatment of chronic pain patients. Whether your patient has cancer or a chronic back pain, the medical board wants to make certain that no patient is inadequately treated. If narcotics are called for, they should be prescribed without fear of reproach from the licensing board. Where does this fear come from?
Physicians' fear of opioids probably stems historically from society's concern about the use of opioids and addicts and addiction back in the 20s and 30s and 40s. As I was going through my medical training in the 50s and 60s, it was clear that most of the physician community felt that the use of chronic opioids was inappropriate, except perhaps in certain cases of cancer pain.
So, what's the prescription for relieving the fear of being sanctioned by the board? A better understanding of exactly how the board functions.
The board is required to investigate any complaint that it receives from any source, and that we go through a full investigative process by the staff, and we have to follow the regulations that are prescribed by law.
There's a widespread misperception that the licensing board is disciplining physicians right and left because of misuse of opiate medications, prescribing too much for too long for the wrong patients. In actuality, that really is not a problem for physicians in our state and probably in many states. The majority of people who serve on the licensing board are physicians who are currently in practice, so we have a real understanding of the problems that the average physician faces in dealing with these types of patients. So as long as the physician is meeting the standard of care, he has little or nothing to worry about from the licensing board.
When the licensing board investigates a complaint and decides to evaluate a physician's practice, the medical record becomes the focus of that review, a peer review. It's usually conducted by two board-certified physicians in the same field as the physician being reviewed.
The board usually subpoenas anywhere from 15 to 20 records of that individual physician as a comparison of the sentinel event to what occurs in his office or surgical setting. The doctor himself is not, or herself is not interviewed. The standard of care is defined as what prudent physicians in the same field would do in the same situation.
Refill February, refill March, refill May.
We can't emphasize enough the importance of keeping complete medical records.
Ooh, must have been in a hurry on this one.
No matter how comprehensive the care may have been, if it's not documented legibly in the medical record, the peer reviewers won't be able to tell if the standard of care has been met.
Ah, now that's better.
The record is no longer just a tool for the doctor's own use, but has become a legal document. In some states, keeping adequate medical records is part of the Medical Practice Act. While it's inappropriate to prescribe opioids to support an addiction, it's equally inappropriate to withhold drugs that will relieve pain, even in the face of dependency intolerance. When narcotics are called for, the Federation of State Medical Boards urges physicians to recognize that tolerance and physical dependence are normal consequences of sustained use of opiate analgesics and are not synonymous with addiction. Still, some physicians fear that prolonged treatment of chronic pain with opioids will turn their patients into addicts.
Probably the most important myth about giving opioids is that everyone is going to become addicted. And certainly people with chronic pain or any type of pain who take opioids, it's very rare that we ever see addiction. That's certainly the most common misperception. Addiction is a psychological dependence in combination with the physiologic dependence. In that circumstance, people will participate in drug-seeking behavior, whereas people who are just dependent usually don't want to have more of the agent on board. The other thing about addiction is that those individuals will continue to take medication despite self-harm. Dependency definitely can be reversed without withdrawal symptoms. It requires a slow and gradual tapering.
High-dosage opioid patients can function quite well in society. We have to remember that these patients are experiencing a lifelong debilitating illness. In fact, as a physician, these patients are going to be with you probably the rest of their lives. In our practice, we have a goodly number of patients who are on high-dose opioids, and these people are functioning normally in society.
A legitimate worry about managing chronic pain patients is the diversion of drugs to the streets. Is the prescription being taken by the patient, or is the doctor being taken?
I've been told that it is a billion-dollar industry, and clearly some of the patients who have bought medications on the street have told me what their medications are selling for. For example, one Percocet may bring $5. There's a myriad of stories I've heard where patients will in fact have lost or, not be able to come up with their medication. Somebody took it on the bus. But again, these are clear symptoms of people who are either diverting their substances or unable to take them as prescribed, and those are symptoms of an addiction problem.
The drug community, or those who are abusing prescription drugs, learn very quickly where there's a nice doctor, a sympathetic doctor, a doctor it's easy to get to see on short notice, and from whom it is easy to leave the office with a prescription for drugs with high drug abuse potential.
The goal of all pain management is to relieve suffering and return the patient to a functional lifestyle. Under-medicating can work against these goals and can even cause a pattern of pseudo-addictive behavior.
Pseudo-addiction and pseudo-addictive behavior occur when a patient has legitimate pain and is receiving opioids for the pain, but the patient recognizes that without the opioids, they will not be able to have a normal lifestyle, they will not be able to be comfortable, they may not be able to get a good night's rest. And so they exhibit or manifest some of the types of behavior that are typical of addiction. This is not true addiction because it does not carry the psychologic aspects of the true addict, but it appears to be in the eyes particularly of a physician who is not familiar with the patient.
The world of medicine changes and advances daily. Continuing your education in pain management assures you and your patient that he or she is getting the best care possible.
For many physicians, there really hasn't been part of their core medical school curriculum training in pain management. So it certainly is important that we get as much education about pain management as possible. Many things that we learn in medical school we perhaps will never encounter in our entire careers, but this is something that everyone will see.
As you walk from the more familiar ground of medicine to the less traveled narrow ledge of treating chronic pain, maintaining your balance gets trickier. The following guidelines for practicing good medicine can help you maintain that balance. First, get to know your patient by doing an evaluation. Take the patient's full history and do an appropriate physical exam. Also, obtain prior records if the complaint precedes your care. Second, record a diagnosis and treatment plan with a specific goal. Whether it's achieving a better night's sleep or returning to work, be specific. Your record should be clear and easy to understand for a subsequent physician, and should include what you were treating and why you chose the plan you did. Doctors are notorious for bad handwriting, deservedly or not, but if you fall into that category, make technology work for you. Third, informed consent. This includes establishing the patient's goals and discussing available therapies. However, when long-term use of narcotics is the course of action, the patient should be informed of the risks of dependency and tolerance, as well as the benefits. If you feel the patient is a high risk for drug abuse, you might want to use a written agreement.
When trust starts to break down, an option is to set up a contract. The contract says all medications are dispensed at an office visit, no early refills. It can say things like, you will continue to go to physical therapy. You'll use just one pharmacy. You won't call in on the weekend and ask my colleague who doesn't know you for prescriptions. All of these things are things you can do to increase your comfort, improve your record keeping, and protect you from giving drugs out in the wrong way. Most of all, you can help the patient much better if you provide a framework for their safe use of narcotics.
Fourth, a periodic review, monitoring the patient's progress in relation to the goals established.
When a physician is taking care of a patient who has a chronic pain condition, it's important for them to see that patient on a regular basis, especially early in the treatment. The reason for doing this is to make sure that the pain is adequately relieved, that the best treatment has been found for the patient, and that the diagnosis is correct as much as is possible.
Patients with chronic pain should be some of the patients we know the very best in our practices. Sometimes when a patient makes a doctor uncomfortable because we can't cure them, there's a tendency to not want to see them so often. But someone who needs narcotic medication chronically should be a patient that the doctor knows.
And always document conversations as well as lab results. Fifth, In order to achieve the treatment objectives, it may be necessary to refer your patient for additional evaluation, a consultation. Patients with a history of substance abuse may require careful supervision and, if indicated, referral to an expert in pain management.
When I do talks for primary care physicians, I list 3 different things where I believe we can be of benefit or of help to the primary care physicians. I feel that our role can be diagnostic, therapeutic, and supportive.
It's very important when a primary care physician refers a patient to a pain center that a lot of records accompany the patient. It's important for the pain center to know what's been tried, what's worked, what hasn't worked, what have been the pitfalls in treating this patient, what have been the successes.
If a physician has been treating a patient, say with Percocet chronically or with MS Contin, but feels quite uncomfortable that maybe they haven't made the right decision, they can refer that patient to us. We can assess the patient and determine whether we think in fact it is appropriate therapy. I think then the primary care physician feels somewhat more comfortable continuing that therapy if we state that yes, this seems to be appropriate, the patient is not showing any signs of inappropriate use of the medication, and we would suggest that they continue the therapy that they have instituted.
A lot of times when I send a patient to a pain treatment center, I expect they'll be gone for a while, but when they return, I need to know where we're going, what the plan is, what my role is going to be. So it's important that I get a prompt, personal follow-up, and not just a letter that says, this is the plan, follow it. What I need is to converse with the doctor who's sending the patient back to my care as to what I feel comfortable doing, what the patient agrees to, and what they feel comfortable doing.
Next, keep complete medical records. They need to be understandable in both form and content and should include the following: patient history, exam, diagnosis, test results, consultations, objectives, treatment and plan, medications, all discussions, agreements, and periodic review. Good patient management and keeping complete medical records are enduring. Finally, the physician who prescribes controlled substances needs to be familiar with federal and local laws regulating their use. The United States Drug Enforcement Administration publishes a physician's manual, and state laws are available through your own medical board. Practicing good medicine is the cure for the common fears associated with treating chronic pain patients. It has no harmful side effects. It keeps the scales in balance. The patient is evaluated properly and treated adequately. And there are no reprisals from your licensing board. Your patient and your practice have achieved a healthy sense of balance.
The main difficulty with treating patients who are in pain is that we don't have a really good objective way of telling whether or not a person hurts or not. We don't have the painometer, which is what we really need. And so we have to depend on the art of medicine, our trust in our patients, and our skills as physicians in order to know what to use, how long to treat, and how to best take care of our patients.
I would hope that the physician who plans to potentially use chronic opioid therapy for his patients will always consider various different other modalities of treatment which can be useful.
Once you have a diagnosis, then I would recommend that they go ahead and treat the pain according to the standard of care with any fair of regulatory agencies looking at their charts as long as they're well documented.
I think it's important to keep in mind that in fact there are recovering addicts or current addicts who do have real pain problems. And just because someone has an addiction problem, it doesn't mean that they should not have their pain treated.
As long as the physician is practicing good medicine and keeping good medical records which document the need for chronic pain medication, the physician need not fear anyone.
In the treatment of chronic pain patients, probably the most important piece of advice is not to count every pill constantly, but rather to pay attention to the functional state of the patient. If your patient is getting better in terms of how they live in their family, how they live in the world, how they work, we're doing the right thing.
Good afternoon, Mrs. Smith.
Hello, doctor. How are you?
What seems to be the problem today?
It hurts when I go like this.
Does it hurt you now when you do that?
Yes, it does.
Well, then don't do it.